Okay, hi everybody. We're back again to give you a little demonstration of some of the respiratory or pulmonary modalities that you're going to be using and seeing in the clinical area. So we're going to talk a little bit about airways. We're going to talk about oxygen administration. We're going to talk about the incentive spirometer, and then we're also going to talk about chest physical therapy, also known as cupping and clapping. So first, let's start with the airway. So I want to show you this is an airway that is placed. So it's kind of a misnomer, right? Because it's not truly an airway. An airway is an endotracheal tube or a tracheostomy tube. This is a placeholder for that airway. And you'll notice that it sort of has some on the inside here, right? Like a ridge. And if you look at it head on, you would technically be able to pass like a suction catheter right down there if you needed to. So this type of airway goes into the patient's mouth to hold the tongue down, right? So we need to measure airways to make sure that we have the proper size. So we go from the earlobe, okay, to the corner of the mouth. So I can tell you right now that this airway is going to be too small for our patient here. So if we went from the earlobe to the corner of the mouth, we're about a centimeter short. Okay, so we would need the next size up. They come in different sizes, different colors, and then when you're placing this, you have the patient's mouth open. Of course, I'm not going to place it in your tummy, don't worry. You're going to have the patient's mouth open. You're going to kind of go sideways and then turn it over the tongue and go down into the back of the throat. So that's going to hold the airway open, can allow for suctioning, and it's sort of a placeholder for an endotracheal tube to keep the tongue out of the way. We also sometimes leave these airways in place even after the endotracheal tube is inserted because, again, it helps to keep the tongue out of the way. Okay? All right, the next thing that we're going to talk about a little bit is oxygen administration. So in the voice thread, I gave a lot more information about oxygen administration, so I'm not really going to go into a lot of detail here, but I do want to show you how two pieces of oxygen administration equipment are used. So first and foremost, we have the nasal cannula. And you'll notice that on one end, we have the actual cannula, the nasal prongs, which are going to go into the patient's nose. And then we have another end that gets attached to an oxygen source. Remember that nasal cannula, or all oxygen, is administered in liters per minute. Sometimes when we use a face mask, those liters per minute are translated into a percentage. But with the nasal cannula, we are only using liters per minute. The maximum is 6 liters per minute. If the patient needs more than that, then we would have to get a mask and provide more liters and a percentage of oxygen. So one thing about these nasal prongs is you'll notice that they have a little bit of a slant to them. So when you're placing them, you want to make sure that the slant is going down so that it's going down into the patient's nose, as opposed to putting them in upside down where the oxygen is just basically going into the top of their nose, right? We also want to make sure that we never put this around a patient's head, right? Because patients could choke on it potentially. Okay, so we're going to put this nasal cannula in Tommy. So after explaining to him, that he needs a little bit of oxygen, we're going to give him this nasal cannula. I'm going to fit these two prongs in your nose, and then this tubing is going to sort of wrap around your ear a little bit, okay? So this goes into the nose, and then we go over one ear, and then we go over the other ear, and then we sort of tighten this a little bit. Not too tight, okay? And then this end is going to get attached to our oxygen source, and we're going to set up the number of liters. So you can see how it looks here, okay? We don't want to find patients with their nasal cannula. I've seen patients with the nasal cannula up here. I see patients with the nasal cannula on their forehead. I see people with the nasal cannula under their chin, right? They're not receiving oxygen if the nasal cannula is in any of those other places besides the nose. Okay, now let's say that Tommy, unfortunately has desaturated. His oxygen saturation on a full 6 liters of nasal cannula is still less than 90%. So my provider tells me that we're going to switch the patient over to a face mask. So the face mask that I have here is referred to as a non-rebreather mask. One thing to keep in mind is that this bag that is attached must be inflated, or your patient is not getting any air at all, let alone oxygen. Okay, so with the non-rebreather or with any mask, let's just talk about general masks. You're going to see this metal piece on the top that you can kind of conform to their bridge of their nose, and there will be some straps, okay? And then, of course, just like our nasal cannula, it has this end piece to be connected to the oxygen source. Generally, when we're using a face mask, we refer to the oxygen in percentages, and each percentage is equal to a certain number of liters per minute. In lab, you're going to be practicing with what we call Venturi masks. You'll also see the simple mask, and then of course you will see the non-rebreather masks. So when we want to place a mask on a patient, we want to be sure that the mask in and of itself is big enough to cover both their nose and their mouth. We also want to make sure that the straps are long enough to go around their head. So first step is holding the strap backward. We're going to put this over Tommy's nose and mouth, and then we're going to take this strap and go forward over his head. Once in place, I'm going to give a little pinch here to get a good fit on Tommy, okay? When we want to remove it, we're going to just simply bring that elastic over and either discard the mask, or perhaps they can step down to, maybe back down to their nasal cannula because they don't need that amount of oxygen anymore. One thing to be careful with masks and with the nasal cannula is about skin breakdown, okay? For the mask, think about that strap going around the back of the head and the amount of pressure that it's putting there. Also think about the bridge of the nose getting reddened and potentially break down there as well. With our nasal cannula, you want to think about behind the ears, okay? Patients can get breakdown behind the ear. So what could we do for that? We can actually put a piece of gauze there and then let the tubing of the nasal cannula sit on the gauze as opposed to right on their skin. So if you have a patient that's using oxygen for long term, you should be assessing skin, nose, back of the head, and behind the ears as well. All right, the next thing that I want to cover is that of the incentive spirometer. So the incentive spirometer is different from the other kind of spirometer you might be thinking about. So we have a spirometer that we can use for pulmonary function tests, right? Where we ask the patient to breathe into the spirometer so that we can measure the exhaled volume of air. With incentive spirometers, what we're doing here is we're trying to promote what we call good pulmonary hygiene or good pulmonary toilet. So what we want the patient to do here is we want them to inhale deeply. Sometimes telling your patient to do it like they're sucking on a straw is helpful. They can kind of get that visual so that they understand what they need to do. So there are really a couple of parts to this incentive spirometer. First of all, we have some tubing with a mouthpiece. Then we have the spirometer in and of itself. It has a little handle here for the patient to hold while they're doing it. Then you'll notice this yellow piece that goes up and down. So we set this as a goal for the patient. So this goes to 2,500 milliliters of air. So how do we determine how much air a patient should be able to inhale? We look at their size, we look at their weight, we look at their age, and we look at their sex. So generally speaking, male patients are going to be able to inhale more air than their female counterparts. Not always the case, but usually it is. Every spirometer comes wrapped inside a plastic bag, and with it comes a chart. And on that chart, you can look your patient's age, their height, their weight, and it's going to tell you how many milliliters that patient should be able to bring into their lungs if they have normal lungs. We use the incentive spirometer to kind of incentivize patients to take deep breaths. We know that when patients are in the hospital, they often spend a lot of time in bed. They're not fully expanding their chest. They end up with that atelectasis that we talked about, that collapse of those small airways. And that in turn can lead to things like pneumonia. So you're going to see these incentive spirometers used a lot in the clinical setting, particularly in patients who are immobile and patients who are post-surgery. All right, so we're going to set it to the amount of air that we have looked on the chart. So for someone of Tommy's age, weight, and height, we're going to set him a goal of 2,000 milliliters, okay? Now, there's another portion to this incentive spirometer here. I'm going to hold it a little bit closer so that you can see it. I want you to concentrate on those three little faces that you see. You have two frowny faces, one at the top, one at the bottom, and in the middle, there's a little smiley face. So there's also this yellow piece here that moves up and down, okay? When your patient takes a deep breath in, not only does this yellow disc move up, but so does this little square yellow piece. What we want patients to do is we want patients to hold the yellow piece in the smiley area. That's actually more important than how high they can go. All right, so let's do a little demonstration. So Tommy, this is an incentive spirometer, and we'd like you to use this since you just had surgery. And we want to make sure that your lungs are getting fully expanded. So I've set your goal at 2,000, and this yellow disc here is going to move up as you take a deep breath in. You want to suck on it like you're sucking on a straw. You want to close your lips around the mouthpiece nice and tight, and then take a nice deep breath and see how you can do. Okay, so let's try one. Okay, so Tommy is actually an overachiever. He was able to get all the way to the top, the 2,500. Probably if it was higher, he could go higher than that. But again, what's really important here? Not how high he can go. So Tommy, what's important is really not how high you can go, but that you can hold this little square yellow piece. See that little smiley face there? I want you to hold that yellow piece in that smiley face area for as long as you can, okay? Okay, sorry about the phone interruption. Let's do it just one more time. Sorry. Okay, so you see by him holding the little square piece, he gets up, can get all the way up to the top again, but what was most important is that he could hold that yellow piece in the smiley face area. So that's the key to this incentive spirometer. It really is not how high the patient can go, but rather that they can hold that breath, that air inside their lungs for that extended period of time to help those little airways all pop open, okay? All right, so the last thing that I want to demonstrate for you is chest physical therapy. So again, when we have patients that are not moving around, patients who are post-general anesthesia, patients who are lying in bed or sitting in a chair for the majority of the time that they're in the hospital, we have to worry about the collapse of those small airways, again, that atelectasis. So the other thing that we're concerned about is pooling of secretions, right? So secretions can, kind of get caught in places, and then they become an environment for bacteria and other, organisms that can cause pneumonia. Right? So we do a technique called cupping and clapping, also known as chest. It's one of the components of chest physical therapy. So what's key here is to get the position of your hand correct. So what you want to do is have your thumb close to your other fingers, and you want to position your hand sort of in a cup, right? As if you were trying to get some water and drink the water from your hand. So you want it to be in a cup. So both hands have to look like this. And then I'm going to ask Tommy if he could turn around for us. And what we're going to do is do some cupping and clapping on his back. Again, I would ask him to lean forward, right? And I'm going to take my two hands like this. I'm going to go down one side, back up again, and then to the other side, making that cupping noise, okay? Both sides. And then after you finish that cupping and clapping, you're then going to ask your patient to take a nice deep breath in and to cough, right? So that any sputum that you've moved around by doing this, he's now able to expectorate that sputum, okay? So that's your chest PT or cupping and clapping. And again, you will practice this on your partners in lab. So again, we appreciate you watching, and I'll see you soon.